So my name is Amy Castiglia. I'm presenting as a SANE. I've been an RN for about 12 years, ICU nurse for 10, SANE for almost 4, also working in outpatient drug and alcohol for about 5. Just before we start, this is definitely could be some triggering information for some people. If you've experienced sexual assault or you know someone who has, so if you need to step away or leave the meeting, I totally understand. I put my email and the email for the society here, just in case like you want to contact later if you had to leave for whatever reason. Just really quickly, New York State Penal Law, Article 130 outlines sex offenses in New York State. I'm not going to talk about these, but you can go ahead and look that up if you're interested to know the various offenses for sexual assault. The one part of that penal law I wanted to just talk about was how New York State defines lack of consent. So we assume that there was lack of consent when there was forcible compulsion, which means that the person was compelled to this particular act by either physical force or threat of immediate death, physical injury, or kidnapping of themselves or another person. We also determined these following persons incapable of consenting to sex if they're less than 17 years old, if they're mentally disabled, which is a mental disease or defect that means they cannot appraise the nature of their conduct. If they're mentally incapacitated, it's kind of similar, but it is a temporary situation in which they cannot appraise their conduct. This is usually being intoxicated. Physically helpless, which just means they are unconscious or for any other reason cannot communicate their unwillingness. And then there's also persons in certain institutionalized settings. There's a few other circumstances I'm not going to touch on because they're way too specific. When I talk about sexual assault, I mean any unwanted or coerced sexual contact. So it includes this list of things, but anything that was unwanted or coerced. I may interchangeably use the term sexual assault and rape, just because rape is a shorter word and it's quicker to get through. One thing I just want to point out on this list is that I think marital rape is something we commonly don't hear as much about, or we may not believe is a thing, but it is. Remember, it's any unwanted or coerced sexual contact, whether you're married, in a relationship, dating, or it's a stranger.
That's true.
Beyond any kind of legal definition, it's really just important to understand that sexual assault is not about sex or sexual attraction or sexual gratification. It's not an act of impulse or something that the person just couldn't control. It's an act of intentional violence, power, control, and domination. It's motivated by anger and or a need to feel powerful by controlling, dominating, or humiliating the victim. So sexual assault is not at all about sex. It is a violent crime and sex is the weapon. There's some national stats. I don't even think I'm really going to go through them too much because this is all stuff you guys can look up later. Just knowing that like reports of attempted or completed rape are about 1 in 5 for women in this country, which is about 21.3%. For men, it's 2.6%. That's a pretty significant difference. I thought this was interesting. Between 2017 and 2018, more than doubled self-report of rape or sexual assault in persons age 12 or older. So in 2018, it's estimated that 734,630 persons in the United States were raped. And this includes whether it was threatened, attempted, or actually completed. Interesting though, between those 2 years, there was actually a decrease in reporting to the police. I have things I could say about that. I think in 2018, we saw the Me Too movement picking up, but I think we also were starting to, potentially see more distrust in police and government institutions and stuff like that. So not that I know that for sure, but that would kind of be my guess. So just moving into the role of the SANE or the SAFE and clarifying those titles. A SAFE is a sexual assault forensic examiner. It includes everyone that potentially practices, so the RN, NP, PA, and MD. A sexual assault nurse examiner is the RN and the NP only. But so I may also interchangeably use SANE and SAFE, but I ultimately mean anyone who's practicing. So to become certified as SAFEs or SANEs have specialized education and clinical preparation in the medical forensic care of the patient who has experienced sexual assault or abuse. I'm going to outline kind of in our county here, because it's what I'm most familiar with, how we become certified. However, I think it's probably either the same or pretty similar for other areas as well. We undergo 41 hours of didactic training, either in person or online. And then it's followed by 40 hours of clinical training, learning the equipment and the paperwork, doing patient simulations, anything just to learn really hands-on. We then sign up for clinical rotation shadowing. So this is when, if I'm brand new, I've just finished those like 80 hours of training, I'm going to go out with an experienced nurse when they take a case and start checking things off of my skills list. Once I've completed everything on that skills list, my application to the New York State Department of Health is submitted for certification as a New York SAFE. And this is something that we recertify for every 3 years. How SANEs and SAFEs practice. The community-based and hospital-based are essentially the same. It's just who's administering the program. So in a community-based situation like we have here in Suffolk County, the program is administered by an outside agency. So all of the SANEs and any other staff are hired by them, and then we are on an on-call schedule to any of the hospitals in the area that participate. If the program is hospital-based, it's administered by that hospital or hospital system. And it depends on the area, I think the volume of the ER and the hospital. So if it's a really high volume ER or a busy hospital, they're likely they're gonna hire their own SANEs, but they'll probably be on call as well. However, if you're in a more rural area where it's possible to maybe not have a very high volume, they may have ER staff in-house that can respond and be reallocated to a SANE case. We also have TeleSafe here in New York. It looks like there's probably about 40 plus hospitals in central New York that they are not DOH SAFE certified. So the provider in the ER can call in and have a SAFE certified provider guide them through the paperwork and the exam and the kit. So this is really helpful, obviously, for filling some gaps and helping out with some critical access hospitals. SAFE exams are conducted up to 120 hours following the assault, and that's just for the forensic evidence collection. It used to be 96 hours. It was within the last few years was increased to 120 just based on better research and better lab techniques. A SANE exam can generally last 4 to 6 hours. It could be less or more depending on the complexity of the case and other circumstances. When a SAFE gets the call, it can either be from the police department or from the hospital. If the patient is already with the police and they're reporting to detectives, the detectives will then call the SANE on call to let them know what's going on and, estimated time of arrival to the hospital for the exam. Patients, unless they're under the age of 12, do not have to report to police in order to get a SANE exam. So they can just go directly to the hospital and say, I've been assaulted or raped or whatever. And what we do in our jurisdiction here is ask the ER providers to just look at the triage checklist that we've provided with them with, just to make sure that the patient actually wants to see us, first of all. I mean, did the assault occur within 120 hours? Do they want to see a forensic nurse? Are they consentable? Which, just because they're intoxicated possibly does not make them not consentable. But if they can't stay awake or they can't hold a conversation, we may postpone for a few hours. We just ask them to draw some labs, save any urine that the patient puts out, and not to disrobe the patient unless absolutely necessary, because we'd like to collect the clothing for evidence. Following getting the call from either PD or the hospital, we're going to call out and see if there is a trainee for that clinical rotation part of the training to join us. We will call for a rape crisis counselor. In our county, they are volunteers, and they are probably the most wonderful people on the planet. They will attend the exam to provide emotional support for the patient while we're doing the exam, and also usually help them see if there's any other resources that might be available. If the patient is 8 years old or less, we call for a second SANE nurse as well. That is our protocol. When we arrive to the hospital to meet the patient, we're going to introduce ourselves. I usually go ahead and explain a little bit about what I do and make sure that they're clear why I'm there. And we obtain consent. Just to point out really quickly that I said earlier, in New York State, consent for sex is age 17, but consent for post-assault care is 12 and up. New York State has a few healthcare related things that the age is different, and this is one of them. Obviously, they have to be able to provide informed consent. So if there's any question about that, or if the patient wants to call mom or a guardian or a sibling in for parts of the consent to help them make the best decision for themselves, that's completely fine. As long as that person is not also the perpetrator. Our program consent form is a line-by-line consent for every step of the process. And we do this because the patients are completely allowed to consent to one part and not others. But it's also more than just a logistical process, because this is a patient that just had something done to them without their consent. And so it is a process of giving power back by letting them have a choice on every single step. We also do a forensic rape examination form. This is particularly important for our services because if the patient does not want to be billed for the exam, or they do not want to charge their own insurance, the Office of Victim Services will reimburse the hospital directly for the cost of everything related to the exam. So the patient doesn't get a bill, and they don't get any mail regarding that visit either. Our documentation is like any other nursing documentation, essentially, obtaining patient information, any kind of medical history, current medications. Some other things we also ask about is recent sexual history, like consensual sex within the last week. And then we get into some details about the assault, and it's all about how we're going to collect our evidence and what we might be looking for. The exam itself is a physical exam, head to toe. It's scalp to toenails, really assessing every part of the patient's body for injury and for any kind of tenderness or pain. It's really important that we minimize discomfort and exposure during that process. So, there's no reason for a patient to ever be completely uncovered. I might examine one arm at a time, just again, remembering this is trauma-informed care. The patient has had something done without their consent and has been uncomfortable or exposed in ways that they were probably not comfortable with. Forensic evidence collection, there's 2 different kits involved, and I'm going to show what the kits look like in a second. There's the sexual offense evidence collection kit, which we don't call it a rape kit, but it's probably how you can hear it in kind of popular culture. It's a box that contains swabs for us looking for DNA in whether it's saliva, semen, touch DNA. And we'll clean out under the patient's fingernails in case there's any of the perpetrator's DNA there from either grabbing or pushing or trying to fight. We may collect some of their hair onto a towel. Any trace evidence, which is like dirt or leaves or anything that might be connected back to the perpetrator or the crime scene. As I said before, if the clothing was worn during the time of the assault, we will collect that. And we will collect underwear even if it wasn't worn at the time of the assault, just because there can be DNA from discharge that has continued to come out. And the other kit that we use if the situation calls for it is drug facilitated sexual assault kit. And that's if we or the patient believes that they have potentially been drugged or given some kind of substance that they did not knowingly take. Our injury documentation is done 2 different ways. We do document it in writing. We take photography, and we draw a traumagram as well. I'm going to show you what those look like. This is the sexual offense evidence collection kit. It is about the size of a shoebox, and it is full of envelopes. Each envelope has inside of it what you need to collect that particular kind of sample. And then each envelope is properly labeled with date and time collected, who collected it, the patient's information. And then once we are complete with the exam, all of those go back in the box, and the box gets sealed in a very particular way that will indicate to anyone who were to receive it that it had not been tampered with. And then all of the information on the outside of the box as well, including chain of custody. This is the drug facilitated sexual assault kit. It's much smaller, a few inches by a few inches. Just includes the stuff that we need to draw blood and collect urine. It also has its own documentation form where we'll just fill out as much information as possible. You know, for example, like if I have a patient that says, well, I had one drink, I had one cocktail, and about 20 minutes after finishing it, I don't remember anything. And I woke up in this weird place. So we're going to document that. We may also document the patient's recreational drug use or whatever they normally do, just to establish their baseline. And this is like the photography. So this is an example of us, how we use an L scale to photograph the injury along with a measurement that can be seen. But we also would draw out a traumagram with any injuries found, including measurements and what it was. Following the exam, just to be clear too, our exam does include a full gynecological exam, speculum insertion. We do swab the vulva, vagina, cervix. There's a, we do all of those things. I just wasn't going to get into too much depth about that. Following the exam, we can offer medications to the patient. This is done in collaboration with the ER physician. So we can offer Plan B to prevent pregnancy, Flagyl to prevent trichomoniasis, Rocephin to prevent gonorrhea, and Zithromax to prevent chlamydia. Those 4 medications are all a one-time dose given at the time of the exam. If it's in the right time frame and if you know, there's no contraindications for that patient. We also can provide Truvada and Icentris for HIV post-exposure prophylaxis. Again, there's a separate screening for this, and it's all discussed with the physician. It's a bit more of a commitment because the patient is going to have to take about a month's worth of twice-a-day medication and do a lot of medical follow-up for this. But you know, it's if started early, it's their best chance to prevent HIV. Our kits also include ibuprofen for any kind of pain and Zofran for nausea. Even for some people, if they weren't nauseous, those first 4 medications are at least like 10 pills. So, you know, medication-induced nausea, we can pre-medicate with that Zofran. When we're discharging the patient, we make very specific recommendations for what kind of follow-up medical care they need, whether they need to go to infectious disease, whether they need to see their regular primary care or go to one of our clinics. We also, if they've consented to having our agency reach out to them, they'll get a phone call in about 24 to 48 hours to be offered counseling and advocacy. Our organization offers legal advocacy. They'll help make those follow-up medical appointments, counseling, group therapy. We also let the patient know on this discharge information where the kit's going. So if they want it released to the police and they've reported to the police, we'll document that. If they would rather have it stored, they can have it stored, and we are currently holding them for 20 plus years. If they need to return to the ER for any kind of further care or other acute conditions, we go ahead and do that as well. After the exam, it's just important to document our chain of custody. Once we've completed the kit and all the paperwork, where did it go? Did we release it to the police department? And if so, who? Did we store the kit? And if so, where? We may also be called to testify in court at a later date for our case. and mandated reporting. I'm not going to get into this, but we're all mandated reporters, either, CPS or vulnerable persons, depending on the situation. In addition to a SANE program, it's recommended that there be a sexual assault response team, or a SART team. It's a multidisciplinary approach. It's basically everybody involved in the administration of the program. So each meeting would have a representative from an advocacy agency, law enforcement, the forensic examiners themselves, crime lab specialists, the DA's office, ER medical director, et cetera. And this is a way of keeping track of the entire program, and just everyone's collaborating to provide high quality victim-centered care, and also hopefully prosecute these cases to the fullest extent. So after the SAFE exam, if there's no police involvement and no kit, we'll call and follow up and about that counseling. If there's no police department, but there is a kit, again, we'll call for counseling, and we'll store that kit for 20 plus years, as I mentioned. I just want to point out here that victims don't report for a number of reasons, and not even all of which I'm going to tell you here, but I think it's important for us to understand why someone may choose, even in the most heinous of a crime, to not report to the police. There can be fear of police or past negative experiences, and those past experiences may not even be personal. They could be intergenerational, racial, historical, just community-based mistrust. Sometimes the perpetrator is an acquaintance, or it's known to that group of friends or the family, and there's a desire to not want to complicate things or be socially isolated from the other people involved. There can also be a very real fear of retaliation from the perpetrator. Our justice system isn't perfect, and we haven't exactly figured out the best ways to keep victims safe. And perpetrators right now with bail reform are in and out of the jail pretty quickly. So the reality of retaliation, unfortunately, is very possible. And so we just need to know, understanding why, I guess, people make these decisions can help us understand, what their concerns are and what's best for their safety. If there is police involvement and a kit, in an ideal world, they investigate, they build their case, they arrest the perpetrator, they present to the prosecutor, and the prosecutor takes the case, and we convict the person. Prosecuting a case requires a lot of victim cooperation, which can be difficult because retelling their story over and over again can be re-traumatizing. And then when being questioned by the prosecutor's office, and they're trying to really nail down your story and poke holes in it, while they're just doing their job to get the story accurate and correct, it can start to feel like the people that are supposed to support you are actually telling you that you're lying. And that can be really traumatizing as well. The prosecution of these cases, I would love to say they're all convicted for the crime that was stated, but unfortunately, a lot of these cases can be pled down, and so the perpetrator receives a plea bargain, which is great on one hand because the victim does not have to go to court and be as involved as a long, drawn-out case. But the perpetrator often pleads guilty to a much lesser charge, and there's no public acknowledgement of what was done. So that can also be difficult. So I say all of this just to point out that when victims report, it doesn't always get prosecuted. And when they get prosecuted, they don't always end up in the conviction or with the justice that we would like to see. I think, I'm not trying to say that people shouldn't report. I think we should continue to strive for better justice for all of our victims. But it's just important to understand what that means for the victims and how we can best support them during this stuff. Justice can be really hard to come by, but we as nurses, as counselors, as advocacy groups, we can provide a lot of hope and healing that any amount of justice can't. I just want to talk about little cultural considerations and why sexual assault persists in our country. And it's based in this rape culture that and I found this multiple definitions. I felt like this was the best and the simplest, is that rape culture is an environment in which rape is prevalent and in which sexual violence against women is normalized and excused in the media and popular culture. Rape culture is perpetuated through the use of misogynistic language, the objectification of women's bodies, and the glamorization of sexual violence, thereby creating a society that disregards women's rights and safety. Rape culture comes through when we blame victims. It comes through when we trivialize sexual assault, saying like boys will be boys, or it's all locker room talk. We don't mean anything. It's sexual harassment and sexually explicit jokes. It's when we publicly scrutinize a woman's choice of what she was wearing or what could she have been thinking. Why did she drink so much? Why did she go out so late? It's how we define malehood as dominant and sexually aggressive and put pressure on men to score. But it's also how we define womanhood as like subservient and submissive and sexually passive, and the pressure on women to like not appear too cold, or you should be a lot prettier if you smiled. When we refuse to take rape accusations seriously, and ultimately when we tell women to avoid getting raped instead of telling men to stop raping people. And so I'm not going to discuss rape safety today, because ultimately that's great if you're talking to maybe younger students about preventative measures. But ultimately all it says is that this wouldn't have happened if you had just dressed differently or not been in that place at that time. And I'm not going to participate in that tonight. While I think there are some safety measures that are worth discussing, it's not going to be part of this presentation. I really love this video. It's only about 2 minutes long, and I think it really very well illustrates how we talk about sexual assaults and how we victim blame. So I'm going to play that.
Hey, did you hear?
No, what's up?
James is dead.
What? Oh my God, what happened?
Apparently somebody killed him at a party.
What party? Was he there alone?
At that big party off campus on Friday.
Oh man, wow. That sucks.
Yeah.
Was he drinking at the party?
Huh? I don't know. I guess some. It was a party after all.
Yeah, because alcohol makes it harder to fight off a murderer, and he may have made some bad choices about who to talk to.
Well, everyone was probably drinking some.
Yeah. I mean, what was he wearing though?
What?
Well, you know how he wears all those V-neck t-shirts?
Yeah, but
I'm just saying, if you don't want to get stabbed in the neck, consider wearing a turtleneck sweater or something.
I don't think that really...
Also, James was super friendly.
Yeah, poor James.
I mean, he was so outgoing.
Yeah, nice guy.
He talked to everyone.
Yeah.
So it's kind of no surprise that he eventually met a murderer.
What?
I'm just saying, if you don't want to get murdered, don't go around talking to strangers at parties and just expect it to be fine. Did he even blow the murder whistle that Student Life gave us?
No, I think it was in his coat. The murder happened so fast.
In his coat. Typical freshman move. I mean, 1 in 5 college students gets murdered. You should have been more careful. No one ever thinks it will happen to them.
I guess. His family must be devastated.
I know. They must be so ashamed that he let himself get murdered like that. It's got to be so embarrassing for them.
What? No, I meant...
So did they find out who did it? I mean, assuming it was a murder and not some assisted suicide thing. Hey, maybe James really wanted this to happen.
No, he definitely didn't. And it was definitely Robert. Some people walked in on the murder, but they didn't think it was any of their business.
Robert? Oh, he's such a nice guy. He's definitely not a murderer.
He is. He definitely did it.
Yeah, well, he just felt like ending James's life, and he did, but he's not like a murderer. Besides, James was such jailbait, you know?
Huh?
I mean, he just had that look that you can totally see wanting to commit a felony and murder him. It's perfectly normal. Poor Robert. Really, it's sad how many young people's lives are ruined just because they kill a few people in college.
So I think it's a really great, it's just such a really great play on the whole thing. And this was another one that was a great kind of turning all of those safety tips on their head, of, how to stop rape. And it kind of turned around all the things that we generally tell women. But like, some of the highlights here is when you see a woman walking by herself, leave her alone. Um, if use the buddy system. If you're not able to stop yourself from assaulting people, ask a friend to stay with you while you are in public. Carry a whistle. If you are worried you might assault someone by accident, you can hand it to the person you are with so they can call for help. And just don't rape. So a lot of these things are is that ultimately we can tell women all of the safety tips in the world, but people, it makes them feel that they have some semblance of control over the situation, in which they don't. We need more men that are more vocal, and we need, better justice for our victims. So I just want to talk a little bit about how we can talk about sexual assault and sexual trauma in our practices. And this is now, moving away from that acute setting where the SANE sees the patient immediately in the aftermath. I'm thinking more about in maybe our practices, whether it's in inpatient rehab or outpatient treatment, or even in homeless shelters, things where we've got a lot of people coming in that have potentially been in some way sexually traumatized in their life. And so we can be doing a lot of really great work from the beginning. So for any facility, it's really important to determine when you're going to screen and how, and then what will you do when someone discloses. I think, any provider that's going to be involved in this, from the initial counselor or nurse, straight through to the final, whoever they will finally be seeing, everyone should have input into how that's going to be, who's going to be involved. Give me 2 seconds to turn that phone off. Okay. Educate all providers on what the protocol is going to be, and figure out what kind of screening you're going to use. There's plenty of them out there that you can adapt for your facility. But create a script and allow people some time to practice, like kind of simulate the situation. And I say that because it takes time for providers to get comfortable asking these questions and talking about them and knowing what to say and how to respond. Also, certain pre-scripted screening tools may have words in them that not all clients are going to understand. So if you say, have you ever been in a situation where something was consensual or non-consensual, they may not know what those words mean, and you need to be able to kind of pivot and define in words that they'll understand. So this tool I like the best because it's a good basis and you can kind of adapt it to however you want to use it. So it's a screening tool called SAVE. I'm going to kind of just go through my thoughts on each step and why I picked this one. So the first one is screen all of your patients for sexual assault. And I think that this might seem self-explanatory, but it's a really good reminder and a way to start off. So I think many, if not most of our clients have experienced sexual trauma. And in most situations, it's just a chicken or egg situation where were they sexually assaulted or traumatized at a young age and now they use alcohol or drugs, or were they sexually assaulted because they use alcohol or drugs? They're all vulnerable persons, and I think that it would be very easy to assume that a young woman who uses IV heroin and is homeless, there's a good chance that she has been sexually traumatized in some way, because there's multiple vulnerabilities there. And we know that that food and shelter and money and drugs can often be exchanged for sexual favors, especially when you do not have a permanent home. But That's not to say that the woman who comes in who's really put together and has a good job and is just there to see you to get, she wants to try to get her license back after a minor DWI. It's not to say that she hasn't been. So when I say screen everyone, kind of check your biases at the door and screen and ask the same questions in the same way to every person that you see. Ask direct questions in a non-judgmental way. There's a lot of shame and stigma attached to sexual assault, as there is to drug use and alcohol use. But I find that, a lot of, like, let's say addicts that I speak to, they'll be real quick to tell you a lot of dumb things that they did or a lot of crazy things that happened to them. But unless you were to specifically ask about sexual trauma, that's not something that's ever going to come up. And I think that people who have experienced this, they tend to push these things down. They think they've gotten over it. They've conveniently forgotten about it as some kind of trauma response. So unless you directly ask, that's not something that's going to be shared. Rather than, I see a lot of agencies tend to say, have you ever been raped or sexually assaulted? And I hate this question. It's way too specific. And because I look at it and I say, if I were asked that question, and my concept of rape or sexual assault is a woman running through Central Park who gets attacked by a stranger, has her clothes ripped off, is forcibly penetrated, and then like left for dead. I'm not going to think that when my uncle used to touch me, or when somebody was a little too pushy or forceful with me that made me uncomfortable, I'm not going to think that that qualifies. And so I'm just going to say no, and you're going to move on. And we missed the opportunity, right, for any kind of counseling. So instead, I'm going to, a question that I really, really love is, have you ever had a sexual experience that bothered you? And this is one that we use in our outpatient. It's direct, but it's wide open. And I will get a multitude of responses to this. Usually the first one being, well, what do you mean? And I just say, it means whatever it means to you. There's no right or wrong answer. If you want to change that up, you could even say, you can kind of change the words if you don't even want to say sexual at all. But I think a question like that is really, really great. And it allows them to explore what's going on in their head. Some people will say no immediately, and then you just use your judgment. If you feel like they're saying no, but there's something else going on behind the curtains there, you have to judge the particular individual in that moment. For some of them, I will say, you look like you went into your head a little bit there for a second, and where did your mind go? Because I'm curious, what were they thinking about and then not saying? But that's only if I feel like it's appropriate to follow up with that question. Otherwise, I'll document, answers and demeanors, and we can always circle back and follow up at later time in treatment. They might say yes, and some people will say yes, but not want to share what, and that's okay. We don't push. We ask, would you like to share with me? If they do, they do. If they don't, they don't. I just always thank them for sharing and trusting me with that information, whether it was just a yes or whether they told me the story. And I encourage them to continue to deal with this in further treatment. I'll usually ask permission to share with the counselor that's going to see them, just so that they can pick it up at a later date. Either way, I'm going to probably document what I heard, but it just feels like a little bit more respectful to ask for permission as well. Validating the patient's response. So this is important because, sometimes the patient might say like, oh, well, this happened, but it wasn't really a big deal. So they're minimizing their experience. Don't do that. Don't, even if they do it, you don't do it. There's nothing small about anything that was inappropriate or uncomfortable or unwanted, whether they were a child or an adult at the time. Again, validating by thanking them for sharing and trusting you. You can, in some situations, acknowledge how difficult that must have been. I'm a little hesitant to say, talk about how brave they are, because we should, it shouldn't be an exceptional thing to talk about. We want to kind of normalize this a bit. And then evaluate, educate, and refer. So by evaluate, just make sure that the patient is actually safe now. Because if this is somebody that they know, if it's their spouse, if it's an acquaintance, you want to just assess for actual physical safety and whether there's other concerns about housing and other social services. Any kind of education, which can be things that these can be materials, it can be verbal education, and know where you're going to refer them to. So if you have in-house counseling for that, great. If you don't, it's really important to be familiar with the domestic violence and sexual assault advocacy agencies in your area, and what kind of services they provide. And so that way you can provide that and let them know, and you can always assist them in making appointments if necessary. Again, this SAVE tool, this is just like a brief overview. It's just something for your consideration to decide how you're going to start asking very specifically in your practice. And there, like I said, there's also a ton of other screening tools that I was a little iffy on, but if they work for your practice, then great. Just some resources. RAIN is the Rape, Abuse, and Incest National Network, the National Sexual Violence Resource Center, and NYSAFE all have a ton of resources on their websites. I know RAIN definitely, and the NSVRC definitely have where you can go in and search your area to see what agencies and other things are out there. Definitely follow up. I would also say, if you aren't already very familiar with what's in your area, do look them up and do make contact, because I'm sure most agencies would love to come in and educate your providers, counselors, nurses, everyone on what they offer, and probably give you even better tips about how to talk to clients. All right, again, that's just my email. If you have, follow-up questions, if you want any of the resources that I used, any of the little tidbits and stuff, I can gladly send them over. If you have more questions, if you think of something later, whatever, I'm always here. And I tried to keep this as quick as possible, and I probably could have talked for hours if I had everything. So if I included everything that I wanted to. So I am going to stop sharing, if that's okay.